What's up, you guys? Welcome back to my channel. For those of you guys that are new here, my name is Morgan. I am a second year medical student in New York City, and we are back with our third rotation recap, which is for my neurology clerkship. Before I start, I just want to say, shout out to New York. They've literally been doing construction outside my apartment, starting at 7 a.m. every morning for 3 weeks. So hopefully it won't be too distracting in the background of this video, but I was like, if I don't record this video now, then I never will. But okay, neurology. With the end of my neurology clerkship, I am halfway through clerkship year. I feel like it was just a couple months ago that I was terrified about taking step one after only having a 1-year preclinical curriculum, and then I was terrified about being the first class at my school to start clerkships only after 11 months of preclinical, and now I'm here. So I've done surgery and psych, so make sure to check out those rotation recaps, and then now neuro. And for reasons that we will see when I kind of dive deeper, I did not do a week in the life. I was just fighting for my life during neuro, and it was so much happening. It was insane. First thing I always like to start with is my rotation schedule. So I will say that it was it's such a mess. So we only had 4 weeks. So we have 4 weeks in neurology, and then the 5th week is integrated neuropsychiatry, because my medical school, NYU, is only one of 4 residency programs in the 4 schools in the country that offers an integrated neuropsych residency program. Another one is MUSC in South Carolina. So my 2 homes. And that was a really interesting week, but of course at Love House is only 4 weeks, and neurology is so vast that it's really hard to be able to see everything. And so it was just such a mess. So my first 2 weeks were on Pediatric Neurology, which was a consult service that covered the 3 hospitals that NYU staffs physicians for. One, did not know that, so we didn't have a touchdown place. So it was getting emails at 11 o'clock at night of these are your patients, and this is what time you need to meet or pre-round, and sometimes I would show up to the round hospital and then have to backtrack, and it was such a mess. And then we're carrying our stuff with us, our book bags, our lunch boxes, everything through the hospital, because we didn't have an office and because we're going through 3 different hospitals. One of the reasons that I actually had ranked Pediatric Neurology higher is it is a more outpatient focused service. So in the morning we're seeing our consults, and then in the afternoons 3 days a week there's clinic. And so I'm awesome, want to do family medicine, so I'm kids, outpatient, this is perfect. But the way that our lecture schedule turned out was every freaking day I either had lecture in the afternoon, or I ended up having, what else did I have? Lecture, or we have a different outpatient service. So it just happened to be the 2 weeks that I was on Pediatric Neurology, there wasn't going to be one day that I was actually going to be able to see the Peds Neuro clinic in the afternoon. So I just had to be hi, can I switch my other outpatient, because I want to actually see the clinic, because the whole reason I picked this is because I want to do some outpatient. So it was interesting. Got to see a little bit of different metabolic diseases, a lot of epilepsy, and then also a lot of babies in the NICU that were under cooling protocol, or parents brought baby in for what they thought might have been seizures, but it was honestly really benign acid reflux. So those were super cute, and it was nice to learn how to do the neuro exam on an infant. So I think that'll definitely help me when I do my peds rotation. But it was hard because I feel I didn't really learn a lot in terms of neurology, so I felt less prepared for shelf and OSCE after doing those 2 weeks. Then I switched and did a week on the Neuro ICU, so that was nice. I was only at 1 hospital. I actually had a touchdown space, but again, all of my patients were not responsive, and so I didn't really learn how to do history or full neuro exam, because you're just checking basic reflexes and stuff in the ICU. That was also a tough week, which we'll go into in a little bit, but yeah. And then I did my final week was on the consult service for like adult neurology. That was honestly my favorite week. I got to see everything from like maybe strokes, like maybe peripheral nerve disease, to like maybe genetic, just like it was so interesting, vast, and a lot of my patients were interacting with me, so I was able to like get full histories and stuff like that. I would arrive about 7 in the morning and then do sign out from the night team, and then I would pre-route all my patients by myself, and then the attending would come, and then we would round on all the patients, and then in the afternoon we'd kind of just like follow up. So like in some afternoons, like I got to see an LP, other times we'd see new consults and different things like that. So that's a little bit about how my schedule went, and then the integrated neuropsych week was mostly lectures. So yeah. How did the rotation go outside of like the schedule? So this was definitely out of like surgery, psych, and neuro. Neuro is definitely my least favorite rotation. I think that the brain is cool. I'm sure it is. And like some of the things that I did get to see, I was like, wow, like this is exciting. And if I had more time to like really explore this, I think I would be interested in it. But I think that like the way that our lecture schedule was organized, like, and we had these like random quizzes, like there was just like too much disorganization that I feel like I didn't really get like full days with the team. So it was hard for me to see like what is the life of like a resident or an attending in neurology, like what does that look like. Also very sad. So a lot of the patients that I saw when I was on pediatric neurology in the ICU, and also on the adult neuro ICU, and so I saw my first patient pass away. Well, let me clarify. So when I was shadowing in undergrad, I was on like a trauma general surgery like overnight shadowing experience, and so we did see someone pass away that night too, but it was definitely more of like, I don't know, that one was like more expected, and it was like more prolonged, like doing CPR and different things like that. But then this one was that I saw on neuro was very different because it was someone in the ICU, so they went DNR, DNI. And so it was just like very, I guess, peaceful, because there wasn't any like, we're not going to intubate the patient, we're not going to do CPR, we're just like trying to keep them comfortable. But it was definitely like sad, I feel like, because when I'm shadowing, I feel like in that like high school, undergrad, when I was shadowing, like I didn't have responsibility for these patients, and like in medical school, like even though you're not the main, like you still have the attending and the resident, like it's nothing that we could have done, like it was just like the natural course of progression for this patient. Like I feel like I now see myself more of in a provider role, and so there's like some responsibility of like, this is my patient and something happened to them. So yeah, that was definitely a lot to come to terms with, but it happened. So definitely a lot of sad things on the on neurology, because I feel like there's just still so much we don't know about the brain, and like while there are so many advancements, there's just still like so much that we can't treat and that we don't understand. And so I think that was kind of tough, but overall I think the brain's cool, and I think with better organization I probably would have enjoyed the rotation a lot more. The things that you guys are always interested in studying for the shelf. So I also think that this was probably like the worst shelf, even compared to the surgery shelf. And after talking to my classmates and just like generally seeing what other people have to say, I've heard it's just like totally awful. And I don't know what I got on my shelf yet, but by the time this video is live, I will know. So I will make sure to put that in the description below for you guys. For the shelf, I did Anki again, so I always do the only step 2 cards. So go to the Anking deck and then do shelf exams, and then neurology, no dupes, only step 2. So there are about 253 Anki cards for that, and so I did all of those, and then after that I started doing some of the step 1 cards. So that just includes like the neuro no dupes. So if you just stop at that tag, I didn't get through all of those, but I got through a good bit of them, and honestly I think it was helpful in terms of like just going back to the basics of what causes different disorders and the, you know, blood territories and different things like that. And I think that the one thing that I didn't focus on enough, which wasn't really like as prominent in U World, and honestly I feel like was a little bit on the NBMEs, but like still just not enough, was like peripheral nerves. So like knowing your like dermatomes, knowing like if there's a radiculopathy or different things like that, like what kind of like path is that going to affect, or like what function will you lose, like what will cause a wrist drop versus a foot drop, different things like that. And then also like metabolic and genetic disease, so like your muscular dystrophies, your Friedreich ataxias, your lysosomal storage diseases, and then also MSK. So like there's so many different ways that back pain can present, and like when is it just like back pain that you should just get like rest and NSAIDs versus what is back pain that like you might need to call a spinal emergency for. So just being familiar with that, I definitely think trying to do a lot more of the step 1 cards would be helpful, or going back to like first aid, or like AMBOSS has a really good study plan that includes a lot of those, like just reading those AMBOSS articles. So I think that would be helpful. There was about 312 U-World questions, so I did all of those, and then I did NBME 8, and then a little bit of like NBME 7 for neurology. But again, I just like have heard that it's like so like random with information that comes out on the neuro shelf exam, and once I took it, I totally agree with that. But you just kind of like, in addition to like all the other stuff like Parkinson's, MS, all the good jazz that like you're definitely going to be aware of, just like go back and focus on the things that I mentioned before. I think you'll be good. Tips for the neuro rotation. We had like preceptorship in the afternoon, which I think was really helpful, because it was like when you're on like neuro, like people are, you know, you need to take care of them immediately. Of course, you want patients waiting to get care for. So I really liked our afternoons where we had preceptorship, where it was just attendings that just volunteered time out of their day, and they weren't necessarily like taking care of patients, but it was just opportunity, like fully learning. So we would find patients that like residents would recommend that were like nice, and they would just let us interview them and do a full neuro exam on them, and we would then like go back and look at their imaging and come up with differential diagnosis, or what we thought happened to the patient. I thought that was super helpful. And on the first day, my attending was like, let me give you guys like the TLDR. So normally for like any other thing in medicine, you're kind of like, okay, I collect all the information, then it's figuring out like prioritizing a differential diagnosis. But in neurology, it's very different. So it's like collecting all the information and then localizing, and then after you localize, and then you can kind of figure out your differential diagnosis. And I think that's because there's a lot of overlap between presentations, but just different things, like when you're considering like a stroke or an infarct, you know, like if your face is involved, so if you're seeing like facial drooping and different things like that, then it's going to be something in the brain, something in the cortex, versus if you only have extremity involvement, then it could be something that's localized to the brain still, but also it could be brainstem, could be spinal cord, or different things like when you're considering like stroke versus Bell's palsy, because like the innervation to the face. So if it's only lower face, could be a stroke, but if it's full face, then you know, it's like lower motor neuron could be more of like a Bell's palsy presentation. And then also like helpful with this is like knowing the different tracts of the spinal cord. So like if there's a spinal cord lesion, to know like, is it in the middle, is it impacting the front, the back, based on if you're seeing impacts with like corticospinal tract, spinal thalamic tract, different things like that. So that was really nice to kind of think like, is it brain, is it brainstem, is it spinal cord, is it neuromuscular junction, is it peripheral nerve, and just kind of going through that. And then, you know, like that's literally like when you're talking to a patient, be like, I think it's peripheral nerve issue. And then when we think about peripheral nerve issues, these are differentials, but first figuring out like where in the nervous system is the deficit coming from. And then this is kind of like for on the wards, but also for shelf exams, know like the big compare and contrast. So like, what are the different causes of vertigo, like benign paroxysmal positional vertigo versus Meniere's versus vestibular neuritis versus labyrinthitis, all of that good jazz. And then different types of migraines, so like different types of headaches, like cluster headache versus migraine versus like a trigeminal neuralgia versus a tension headache, different things like that. They love to kind of make sure you know the differences. And then stroke types, so like hemorrhagic versus ischemic, and then even with ischemic, like embolic versus thrombotic, and how those present. And then different territories, so like ACA, you're going to see leg weakness more than arm weakness, MCA, like face and arm, PCA, that like vision, different things like that. And then for the wards, make sure you know how to read your MRIs, so know like, or just like imaging in general, so like know what a CT scan looks like versus an MRI. And then within an MRI, like do you know if it's T1, T2, FLAIR, all that good jazz. There's so many like good resources online to look at those, but imaging is critical. I feel like I kind of got through like surgery. I mean, I'd look at like some CTs for surgery. I was on colorectal, so I'm like, okay, small bowel obstruction, or like I can see like an obstruction from a tumor, different things like that. Psych, didn't really look at any imaging, but neuro, I was looking at imaging like every single day, and you're always like comparing and contrasting from prior imaging, and there's certain things that like if you see atrophy in this lobe, then it's more likely this disease. So make sure you're very comfortable with looking at imaging, and of course it'll come, but if you can just kind of have like background information of knowing what imaging you're looking at and what the territories are, I think that would be super helpful. And then of course make sure you know your neuro exam, make sure that you have your tools. They absolutely do not like the triangular reflex hammer, so make sure you invest in a good reflex hammer. Make sure you have a pen light, make sure you have a tuning fork. Your tuning fork is going to be perfect because you can use it for vibration, but you can also use it for cold, so that can look at pain and temp, and then you can use the back of your reflex hammer to do like Babinski, and you can also use it for like prickly to again test for pain, so you don't have to worry about like finding like you always get like cotton swabs and you break it in half, but like that's wood, and I'm like, what if I give someone a splinter? Like I don't want to add anything else, so I just like having like something that's more benign when I'm doing the neuro exam. I'll link all of that below so you guys can just like grab the set that I got. It was super helpful. Like I'm always carrying it around. A lot of times my attendings were like, all right, who has the tools? I'm like, pin light, ready to go. But yeah, just making sure you know like how to do a full neuro exam, and like doing that with patient safety. So like when you're doing gait and you're testing for Romberg, like you need to be around the patient, so in case they fall back, you're there to catch them. And then what, like if it's an abnormal exam, what do the abnormal findings mean? So that was a lot, but yeah. And of course, like the general tip that I always say is like set expectations with your residents, attendings at the beginning, in terms of like if you're writing notes, should you pre-round, should you only what parts of the exam should you do with the attending versus by yourself, different things like that. But overall, I really hope that you guys enjoy neurology. I think it's interesting. The brain is honestly super cool, and just like seeing how interconnected and like how complex it is was really exciting. Hopefully you guys have more longitudinal experiences on your rotations, and hopefully the tips that I shared for the shelf exam will help you exceed not only on your rotation but also on the shelf exam. So good luck, and I'll be back next time.